Hi everybody. As Avril said, my name is Charlotte Foley. I'm talking on behalf of the Lakes DHB team because I am the self-confessed data nerd for the team.
Every team needs one, Charlotte.
At least one. So I come from a background of being a lab scientist as well, so I quite like the science of improvement as well. So I'm just going to talk quickly about our project so far and how we got to choosing our measures and where we're up to. So our primary aim is to reduce the incidence of constipation related to opioid use in orthopaedic inpatients by 50% by June 2016. And we've also put in an overall aim regarding all opioid-related harm because we do believe that if we influence one, in theory, we should influence all the others as well. So a quick look at our driver diagram. It is a very busy slide, unfortunately, trying to fit it on one page. I don't know if you can quite see that down the yellow column there, some of these are in different colour. Those are the ones that we're actually doing some work on at the moment and hoping to influence some of our drivers. So we structured our driver diagram around the patient, and we took the theory that if we actually look at the things that cause constipation in a patient, then as primary drivers, then all the other drivers should fit into that. Because we do want to remember this is about the patient, so that's why we went down that track. So this is probably about 2/3 of our data collection plan. We've got the outcome measures up the top there. Oops. Right one, there we go. And we've got a mixture of data collection methods as well because we're doing the Partners in Care program alongside this collaborative. We have spent a lot of time talking to patients as well. So some of the measures are around audit of files and some of them are about patient interviews and what patients are saying to us. And actually we are working on comparing some of them. So we actually have, in our measures, we have the rate of constipation from file audit and also the rate of constipation from what patients report, which you'd think might be different. They're actually quite similar, but our overall harm is looking quite different. The columns in the data collection plan, there's quite a few of them, but it's quite handy to have that plan because it keeps people on the same page. And it means if I get hit by a bus and the rest of my team get hit by a bus tomorrow, then somebody else can pick it up and know what we're actually doing with a bit of luck. We have had to be quite specific around some of the definitions because I thought it was clear, and then when Prem came for the site visit he said, well what 5 patients? How are you choosing your 5 patients? And we all knew we were choosing patients who had a length of stay of more than 3 days, but nobody else did. Our data collection is prospective. We started out retrospective, but as Avril alluded to, retrospective is just really hard work. And we really wanted to interview the same patients whose files we were auditing as much as possible because then we can do some paired comparisons down the track. So having the plan is useful. It does keep us on track and it drives the identification of the need for good operational definitions and the redefinition of these at times, as we've had quite a fluctuating project team because we've got house officers who change rotations and we've got large changes in our pharmacy staff at the moment as well. It's really important that we have definitions that everybody understands so that as those people come in and out of the group, they can help us and we're all on the same page. So very quickly, some of you who were at the Midland Learning Session 0 and Prem did it again at Learning Session 1 would remember the exercise we did around operational definitions and soccer goals. This one was the bone of contention. This was the third one. The other two were easy. We're not going to repeat them. So just quick show of hands. Do you think that this is a goal or not a goal? Hands up if you think it's a goal. Not too many. You guys have all been watching FIFA, the under-20s. You know all the rules. It doesn't work so well after everybody knows all the rules. So the picture on the left was our original definition. The two previous workshops, we had about a 50-50 split of people who thought that it was goal. If we redefine the operational definition and say the ball has to be completely past the post or the crossbar in the same way that the ball cannot be touching the line, goal or no goal? No goal. So what that tells us is while the original operational definition worked for the first couple of scenarios, the easy ones, when we get to something a little trickier, we need to redefine the definition so that everybody can count the same thing reliably. So back to our journey, we had multiple iterations of our audit tool and the patient interview. I think we got up to something like version 13 of the interview, and there are still things I think we could change, and 7 or 8 of the audit tool. So we did, I suppose, run a bunch of informal PDSAs on those to make sure that we were achieving the data we actually wanted. As you all know, resourcing data collection can be a bit of a nightmare when we're all working on this project amongst multiple other things that we all have to do in our jobs. We are doing 5 files a week. We were doing 5 interviews a week as well, but we've now just dropped that back to 5 a fortnight because the Partners in Care is finished, but we do think there's still a little bit of, the stuff in there that is useful for us on an ongoing basis. We added process measures around documentation because we went out and we thought we had it sussed, and we went out to measure our constipation and worked out we had a number of patients for whom we couldn't actually tell. So we put in a measure about that instead. And happily that's actually dropped now. We're not getting patients that we can't tell. So this is kind of a dashboard of just the constipation related stuff. I left the overall harm out because it is a very busy slide. On the top left there, that is the rate of constipation it's a percentage actually, of constipation in the file, on patient files, and top right is the patient-reported constipation. And the medians are close enough to say that there's not actually too much significant difference, although interestingly enough, since we've interviewed and measured against the same patients, the lines aren't as similar as you'd like to think they might be. The middle row there is around the process measures for documentation. So the one on the left is the ones that we couldn't tell. So you'll see that's actually down consistently at 0. There might be a point we drop that measurement off and put in another one. And on the right, it's the recording on our EWS, which is our early warning score observation sheet. And at the bottom, we've got patients who are receiving prophylactic laxatives, and on the bottom right, patients who are receiving Kiwi Crush. Now this one here, you'll see it went up for a little while and then it's come back down. We think that's due to our house officer rotation, but we're not 100% sure at this stage, because we had a house officer on the project team who was quite proactive, and we noticed a prescribing change, and then a couple of them left. We got a new bunch and we haven't converted them yet. So we hope that that's what it was about, because that does mean that we can influence some change down the track for those people. And then just because, using this methodology is quite new for us as a DHB, and there are a lot of people who look at graphs and do yawn and go to sleep, unfortunately, we just looked at our qualitative data a little bit differently and did some wordles on our patient interviews and the patient's preferred laxative therapy, which overwhelmingly does show that they'd prefer to have natural alternatives. Whatever is in there. Whatever works, I just don't want to go there. But overwhelmingly they do want fruit, so that's going to be one of our changes we're going to test, is actually having the Prunes Kiwi fruit, or Kiwi Crush actually, on the breakfast tray for that orthopaedic ward. And this was just the themes from the patient's comments as well. And that's a mixture, but for them, and we were interviewing about overall opioid harm, and so for them, you can still see the constipation features quite highly there. even though we're talking about all harm. So that's me. I don't know that we've got time for questions particularly, have we? So
maybe one question if anybody's got any question for Charlotte. Otherwise, I'm sure that she'd be happy to talk to you over lunch.
yeah, that's fine.
Yeah. No? Okay. Cool. Thank you, Charlotte.